Okay, now a good time? Okay. So I have a question. So if a healthcare worker gets the hepatitis B vaccine series, and you do a post-vaccination serology and it comes back negative, what do you do? You start the series, be really careful. Be really careful and start the series again. Yes, both. You start the series again, all 3 shots. So if a healthcare worker, or anyone for that matter, where the hepatitis B serology is important, is you give the first 3 shots, you do post-vaccination testing. If it comes back negative, you repeat the series, all 3 shots. What if it comes back negative after that? You ask for a refund? Should they? What do you do? You give it twice, 2 series, and then you stop. So the studies have shown that those folks who do not respond after receiving 2 series are immune. They just never acquire hepatitis B. But for something peculiar about them, for lack of a better word, they just don't mount an antibody response. Okay? So remember that. If someone fails to respond to the first series, you repeat post-vaccination testing, you repeat the series, and then you stop. Okay. So let's talk about hepatitis C. So hepatitis C is a member of the flavivirus family. Other members include yellow fever virus and dengue. Has anyone here ever had dengue before? I have. It's not fun. Enveloped single-stranded RNA virus. Humans and chimpanzees are the only known reservoirs, and there are 6 serotypes or genotypes and multiple subtypes based on high variability of enveloped glycoproteins. And so you don't have to know this, but just eventually you will, but I'll just tell you that the different serotypes all respond to treatment course differently. And the type that's most common in the United States, very, very, very treatment resistant. The type that's found in Southeast Asia more commonly is much more treatment sensitive. If you're an infectious disease doctor, then you have to know all 6 types and the subtypes, but for medical school and general medicine, we'll forgive you. Here's hepatitis C infections in the United States from 1985 to 89, about 242,000 cases. For 2001 alone, it was about 25,000 cases, new cases. Deaths from acute liver failure is rare. Persons ever infected, about 3.9 million. Persons with chronic infection, about 2.7 million. Hepatitis C-related chronic liver disease occurs in about 40 to 60%, much higher than Hep B, definitely higher than Hep A, where you don't have that. And deaths from chronic liver disease per year is about 8,000 to 10,000. Pretty high. Here's the estimated incidence of acute hepatitis C infection in the United States from 1960 to 2000. Here is, on the y-axis, new infections per 100,000. On the x-axis, the year. You notice that it has increased and then decreased. There's been a decline in injection drug users and decline in transfusion recipients. And it's probably just due to our increased awareness and testing, as well as universal precautions and so on. There's no vaccine for hepatitis C. Okay. So exposure is known to be associated with hepatitis C infection, injecting drug use, transfusion, or transplant from an infected donor, occupational exposure to blood, mostly needle sticks, iatrogenic, unsafe injections, birth to hepatitis C infected mother, and sex with an infected partner or multiple sex partners. Now, this is not a very efficient way of transmitting Hep C, I say injecting drug use, but it certainly can occur. So, you see here, injecting drug use is about 60% of cases, whereas sexual is about 15%, transfusion is about 10% before screening, occupational about 4%, and unknown is about 10%. Any questions so far? Here's post-transfusion hepatitis C, the percent of recipients infected versus the year, all volunteer donors, hepatitis B surface antigen testing. You notice the big decline once we start looking for it. Donor screening for HIV risk factors. Anti-HIV antibody tests became available in about 87. Screening for ALT and anti-hepatitis B core, then anti-hepatitis C, and improved hepatitis C tests. So once we start looking and screening, there's been a gradual decline, well, not gradual, dramatic decline in hepatitis. Once we start screening for either by laboratory tests or risk factors. Is that clear? Sort of, kind of? I probably shouldn't have Hep C here because that's what's confusing you. I should just say post-transfusion hepatitis, and it's all of them, C and B, and then HIV is also associated with hepatitis B. They tend to go together. So once we start looking and screening, the prevalence has dramatically decreased over time. Injecting drug use and Hep C transmission, highly efficient. Contamination of drug paraphernalia, not just needles and syringes. You know, hepatitis B and hepatitis C are really very hardy viruses. I mean, they live on surfaces. Unlike HIV, HIV doesn't live for very long outside of the body. So if you were to go into a patient's room and there's some dried blood on a sheet, and you sit on, whatever you do on the sheets, which you shouldn't, right? I'd be more worried about hepatitis B and C as opposed to HIV. Different from a needle stick, right? If there's a needle stick that has fresh blood and a hollow bored needle and so on, then we have to talk more about HIV. But as far as just simple contact to intact skin, more worried about hepatitis B and C than you would HIV. Right? Rapidly acquired after initiation, 30% prevalence after 3 years, 50% after 5 years, 4 times more common than HIV. Inefficient by occupational exposure, but can occur. Average incidence 1.8% following needle stick, associated with hollow bore needles, just like HIV. Case reports of transmission from blood splash to eye, right? Someone comes in with an abscess or something and you try to lance it and it squirts right in your face. That's why glasses are good. It's better to be 4 eyes, because it works. Okay, 1 from exposure to non-intact skin. Prevalence 1 to 2% among healthcare workers, lower than adults in the general population, and 10 times lower than for hepatitis B infection. So it's hepatitis B, most efficient, followed by hepatitis C, followed by HIV. How many times have I done that? All right, good. Transmission only from women with hepatitis C RNA positive at delivery. So the woman must have a viremia going on for transmission to occur. Average rate of infection is 6%, higher, 17% if the woman is co-infected with HIV. So women or men who are HIV infected will have a higher hepatitis C viral load. No association with delivery method, no association with breastfeeding. So if you have hepatitis C and B, you can breastfeed. If you have HIV, you can breastfeed, but you shouldn't. Right? Make sense? Because the infant can acquire HIV from breastfeeding, but you won't acquire hepatitis C from breastfeeding. Okay. Infected infants do well. Severe hepatitis is rare. Unlike hepatitis B, where infants are very likely to become chronically infected. Are you noticing the difference between them? Good. I gather that means yes. Okay. Sexual transmission occurs, but efficiency is low, rare between long-term steady partners. So, for example, if someone shows up in your office and for some strange reason you decide to do a hepatitis C test, and the person has been married for 10 years, 15 years, and they're freaking out, right? One of the questions they're going to ask you is, should I start now using condoms with my partner? What do you say? They There's only two answers. So, so you have 50% odds. So half of the room say yes and half say no. Well, if they have been married for any period of time and one is positive and they haven't worn condoms, then you say keep doing what you've been doing. Right? It's very not so officially sexually transmitted. There are many couples, regardless of what's her name, Pamela Anderson says, regardless of what she says. Very, very, right? It's more likely drug use. Okay. But I didn't say that. Factors that facilitate transmission between partners is unknown, right? Accounts for 15 to 20% of acute and chronic infections in the United States partner studies. Low prevalence among long-term partners. Infections might be due to common percutaneous exposures, example, drug use, but male to female transmission more efficient, which is more indicative of sexual transmission. So it's less likely to be sexually transmitted, more likely to be drug use, but it can be sexually transmitted. So if someone comes in and says, I think I got it through sex, you don't say they're crazy, unless they're Pamela Anderson, because it can occur. Okay. Household transmission. Rare, but not absent, could occur through percutaneous or mucosal exposure to blood. Contaminated equipment used for home therapies. So if you have a family member, aunt, uncle, niece, or nephew who has hepatitis C and you're caring for them, you are at risk, and healthcare worker. Theoretically, through sharing of contaminated personal articles. So if you share razors with your buddy, or you share a toothbrush with your cousin, not a good idea, but has occurred. All right? Don't know why you would want to do that, but if you're going on a camping trip and you forgot yours. Actually, there's a lot, it didn't become a lawsuit, but as a resident, there was a mafia person who, this is in the heights of HIV, and it's a true story, decided that he didn't want the hospital blood. His brother would give, they had the same blood type. He wanted his brother's blood, try saying that fast, his brother's blood for the transfusion. And he got it. You know what happened? His brother was HIV positive. Guess who got HIV and which hospital settled out of court? All right, so you never know. And that's true, I'm not making that up. Taught me a lesson. And I wasn't the resident, for the record. Okay, so other potential exposures to blood. No or insufficient data showing increased risks from intranasal cocaine use, tattoos, body piercing, acupuncture, military service, but certainly when I think about hepatitis B, in this case, no associations in acute case control or population-based studies, cross-sectional studies in highly selected groups with inconsistent results. So temporal relationship between exposure and infection is usually unknown, biologically plausible, but association or causal relationship not established. So there's still some things that need to be worked out. Pathogenesis. So it also affects the hepatocytes. Much like hepatitis A and B, you have liver damage and clinical illness due more to elicited immune response as opposed to direct cytopathic effect. Like other chronic liver diseases, Hep B and chronic alcoholism can cause hepatocellular carcinoma. In fact, you don't want to have hepatitis B and hepatitis C and drink alcohol. If you want to knock yourself off real fast, try that combination. Not good. Some genotypes that I mentioned before are more amenable to therapy, example 3. But in the United States, it's type 1 that's more common, that's very resistant to treatment. Incubation period in weeks, average 6 to 7. Range 2 to 26 weeks. Acute illness, jaundice is mild, less than 20%. See, less so than hepatitis A or less so than hepatitis B. Case fatality rate is low but can occur. Chronic infection in 60 to 85%. This is higher than hepatitis B. Chronic hepatitis age-related, 10% to 70%, most asymptomatic, and about less than 5% to 20% will develop cirrhosis. And the mortality from chronic liver disease is about 1 to 5%. So both hepatitis B and hepatitis C can be fatal. Hepatitis A is not. All right? Both hepatitis B and C can lead to a chronic infection, but hepatitis C is more likely to develop a chronic infection. Both hepatitis B and C can lead to hepatocellular carcinoma, and they're both made worse by alcohol. Okay. So Hep C, acute infection, asymptomatic in over 80% of patients. When present, acute illness usually mild. In fact, patients will flip out because they'll come and, for some reason, somebody orders a hepatitis C, or, I want to be tested for everything known to man and God. And hepatitis C invariably ends up being one of them. And, this good girl who goes to church every day of the week has hepatitis C. And she never used drugs, right? She never had sex, she says, but she has hepatitis C. Because you can acquire it without even knowing. And that's because the virus also lives on, as I said, it's very hard, it lives on surfaces. So who knows where you got it, right? Question. I shouldn't say good girl, I should say good boy, just to be fair. But, yeah, she could transmit it. What happens is that the HIV, unlike hepatitis C, right? HIV lives everywhere in your body, every place we ever looked, particularly cells that have CD4 receptors. Hepatitis C and hepatitis B lives in your liver. In order for it to be in the rest of your body, you have to have a viremia. Cells die and release the virus, and the virus gets transported through your body. So only if the mother has a viremia at the time that she transmits it to the baby. In chronic cases, the mother might have very low levels of the virus, and she could have very low or undetectable levels of the virus. And in fact, it's one of the problems with testing for hepatitis C is someone can have hepatitis C and you test for it, and the test comes back negative because they're having a viremia. The levels are up and down, up and down. Doesn't mean they don't have it. It's just based on when you test. Unlike HIV, you always have a viremia. So no matter when you test, the person is always positive. All right? That's an important distinction. But even for HIV, there's a higher risk of transmission to the infant based on how high the viral load is. And that's the whole goal of giving AZT during pregnancy, during labor, and after labor, is to decrease the viral load substantially. Did I clarify that for you? Okay. When you have symptoms, jaundice, nausea, abdominal pain, loss of appetite, dark urine, so you see right away all three of the hepatitis, or four, A, B, C, D, same symptoms. Hepatitis C, acute infection, 15% recovery and clearance, but 85% have a persistent infection, which go on to develop a chronic hepatitis, 6% liver failure, 20% cirrhosis, and 4% hepatocellular carcinoma. Where, I know, see, somebody's smart. She's doing the math and she adds up the percentages. And she asked me, what happened to the other people? They don't get any of these. They say chronic hepatitis. Yeah, say chronic hepatitis. Well, that's a good question, yeah. But you never know. Another way of asking the question is, are there predictors of someone who's going to move on to that? And certainly if any other insult to the liver, so alcohol is the most famous one, it's certainly going to push you there. Hepatitis C and hepatitis B doesn't make HIV worse, but HIV makes Hep C worse and Hep B worse. All right? So there are certain cofactors that can make you more ill. It's a good question, thanks. So there's some extrahepatic manifestations. Some are probably due to immune complexes, but some of these you encounter in your rheumatology and some of those complicated internal medicine class, but mixed cryoglobulin, that word, vasculitis, skin rash, fatigue, porphyria cutanea tarda, membranoproliferative glomerulonephritis, questionable diabetes, other autoimmune disease. When you get to be an infectious disease doc, you quickly forget intentionally what some of these things are. But that's what some of them look like. Porphyria cutanea tarda. Okay. So factors promoting progression of severity. So increased alcohol intake. Age greater than 40. So if you're Peter's age, at time of infection. HIV co-infection, if you're male, or chronic hep B co-infection. Right? So, so a lot of people don't progress to hepatocellular carcinoma, but as you get older and you start drinking and, or maybe you're drinking now, but it gets worse. She says yes. Here's that graph that keeps coming up, and I won't even talk about it. Okay, so here's the diagnosis. It's the ELISA, enzyme-linked immunosorbent assay. It's a serologic test, which is usually positive within 2 to 5 months after infection. Third-generation assay is now 99% specific and sensitive, and I'm going to say a little bit more about this. But a confirmatory testing is either PCR, which is positive 1 to 2 weeks post-infection, both quantitative and qualitative, or REBA, recombinant immune blood assay, looks for 2 or more antibodies. And then there's genotype testing done when treatment anticipated. Now, ELISA is associated with false positive and false negative. If somebody has a negative ELISA for hepatitis C, doesn't mean that they don't have hepatitis C, right? Because you have a high false negative rate. So you have to repeat it. Or let me back up. High false positive. If it comes back positive, doesn't mean that they have hepatitis C. You have to do a confirmatory test. So it's similar to HIV. Right? HIV has an ELISA and has a Western blot. So never stop at an ELISA. And we see that all the time. Providers will order. The lab will only do a screening test for hepatitis C and stop if it comes back positive. That's different from HIV. For HIV, if the lab does an ELISA and the ELISA comes back positive, then the lab automatically does a Western blot. Right? Not so for hepatitis C. For hepatitis C, when they report out a positive ELISA, you have to now order a PCR or a REBA based on what's done in your hospital. Understand? Otherwise, if you don't do that, you make us folks at the health department crazy, because hep C is reportable. And if you're reporting all the hep C ELISA to us, we go crazy. And we do. We come find you. All right? So always remember that the lab, if you order hepatitis C antibody, the lab does an ELISA and reports it out positive or negative. If the ELISA comes back positive, you need now to order a confirmatory test, which could be either a PCR or a REBA. Not so for HIV. HIV, the lab does an ELISA. If the ELISA is positive, the lab automatically does a Western blot, which is a confirmatory test. Question?
Why would you use the PCR first and put positive before the ELISA?
Because the PCR costs a lot of money. Costs a lot of money. And the PCR, too, because of the way how hep C is. Remember I said there's viremia. So you have bursts. So you might do it and it comes back negative as well. That's a good question. Uh-oh. Mm-hmm. It's automatic for HIV, yeah. And the ELISA for hepatitis C has a high false positive. I think that's even more crucial point. It's a high false positive. Yeah, and that part, it depends on the assay, but it makes no sense. This is a CDC slide. It makes no sense, because in the real world, yeah, I know.
Okay, so pretty much don't believe what that says, what you're saying?
Yeah. Yeah. It's after I put it up, I go, wait a second, it's really 99%, specific sense? Yeah.
Well, I can see.
Here's how they counter it. There's some labs that have standardized the ELISA. They call it a signal to cutoff ratio. If the signal to cutoff ratio is greater than 3, so they standardize in a lab, they do, like 50 different ELISA, and the ELISA is a colorimetric assay. So they say if all the colors fall between here and here, with our experience, anything that's greater than 3 is positive. So in some cases, not all hospitals will have the PCR REBA. They'll give you a signal to cutoff ratio, and they'll tell you whether it's greater than 3 or less than 3. But that's a standardized assay. So I guess the take-home point is when you get an ELISA for hepatitis C, just be cautious. Know which facility you're working in. and how the diagnosis is made in those places. That's a good point. Appreciate that. Or call me, all right, if you're here. Okay. So based on increased risk for infection, hepatitis C testing is routinely recommended if you've ever injected illegal drugs, received clotting factors made before 1987, received blood organs before July 1992, ever on chronic hemodialysis or evidence of liver disease, or routinely recommended based on need for exposure management, so healthcare, emergency, public safety workers, after needle stick mucosal exposures, hepatitis C positive blood, or children born to hepatitis C positive women. But if you would know that for the mama, you would check a viral load at delivery. So medical evaluation and management, so assess for biochemical evidence of chronic liver disease, assess for severity of disease and possible treatment according to current practice guidelines. About 40-50% sustained response to antiviral combination therapy, so pegylated interferon and ribavirin is a treatment for hepatitis C, pegylated interferon and ribavirin, and vaccinate against hepatitis A. The last thing you want is to know that your patient has hepatitis C or have hepatitis B and you never vaccinated against hepatitis A. They go somewhere on vacation and come back with hepatitis A. It makes hepatitis C or B worse. Right? Counsel to reduce further harm to liver. Stop drinking, right? No matter what disease you have, stop drinking. It doesn't make it any better. So standard of care is pegylated interferon and ribavirin. Many viruses treatment as the above regimen is difficult to take and has many systemic side effects. Fatigue, it's almost like flu-like syndrome. You're flat in your back. The treatment is for about 24 weeks or a year, depending on whether you're co-infected or not. Myalgias, depression to the point of suicide, which has happened. Anemia, to name a few. In fact, some patients will get psychotic and will threaten to kill you, and some have. All right? And I'm not making that up. People get really sick with pegylated interferon. And the overall response rate to treatment is 40 to 50%. Just higher for non-1 genotypes. It's about maybe 60 to 75%. But that's not good for something you have to take for several weeks and feel very sick. And it's hard, too, in that as a provider, you don't know whether it's a side effect of the medicine or is the person really sick. And if someone says, I haven't been able to get out of bed for the last 2 or 3 weeks and I feel like I want to kill myself, do you say, oh, it's all right, we're treating your hep C, go home? Bad idea. So a lot of these patients end up on antidepressants. They have thyroid problems. They end up on Synthroid. You have to treat the symptoms. Question? Yes. Yeah, you can treat. So it's symptomatic treatment. But a lot of providers are very terrified because you can't tell. A lot of the patients who come in requiring treatment tend to have a lot of other stuff going. Imagine your alcoholic who comes in who has hepatitis C. And they're telling you, I just can't get out of bed and, feel like I'm going to kill myself and I know I used to use drugs. You don't know whether you try to encourage them along and say, hang in there, buddy. In a year you'll feel better. Go home, and that's why treatment for hepatitis B and C has gotten so specialized. It used to be primarily just GI docs because gastroenterologists could do a biopsy. Now it's shifting towards infectious disease docs because they're developing various blood tests that tells you the severity of the liver infection. So ID docs, we have no procedures, so we give it to the GI doc, but that's changing. But you need a doctor who has expertise and has seen a lot of patients, so you're comfortable with when a patient reports some of these symptoms, whether to prescribe something or you need to admit them to the hospital or stop treatment. All right? Questions? Treatment, yeah, one of the treatment. I wish I brought in the list. There's about 15 different side effects or more to pegylated interferon. It's a lot. Just name a side effect, and pegylated interferon, does it. It's horrible, but we give it anyway. So, immunoglobulin antivirus not recommended for prophylaxis. So that's different from hepatitis A and B. For hepatitis A and B, there's immunoglobulin. right? That's available. Follow up after needle sticks, sharps, or mucosal exposures to hepatitis C positive blood. You test the source for anti-hepatitis C, the test worker if source anti-hepatitis C positive, and then you do a baseline and you follow up 4 to 6 months later. But each facility has their guidelines as far as frequency of follow-up. But certainly you want to follow up. And you confirm all hepatitis C results with a REBA or PCR, and refer infected worker to specialists for medical evaluation and management. Don't forget that. Employee health. So, anti-hepatitis C positive persons should be considered potentially infectious, keep cuts and skins covered, be informed of the potential for sexual transmission, be informed of the potential for perinatal transmission, but no evidence to advise against pregnancy or breastfeeding, so you can breastfeed if you're hep C positive. Anti-hepatitis C positive persons should not donate blood, organs, tissues, or semen, share household articles, example, toothbrushes or razors. All right? Hepatitis E. Any questions so far? No? Good. Okay, so hepatitis E is a non-enveloped single-stranded RNA virus. It resembles a calcivirus or Norwalk agent that gives the diarrheal outbreaks on cruise ships that you spend $2,000 for and stay inside and have diarrhea all the time. These are actually fun. One of the things we do is your Epidemic Intelligence Service officer at CDC is a public health investigator. And the cruise ships will have an outbreak where you'll have, 400 people who paid a lot of money for a week's trip all have diarrhea. And they'll fly you out to investigate it, somewhere in Mexico and fly you back 2 days later. But they're always fun because there's so many things that somebody could eat. And when you go away, things that you never usually touch. But this virus is extremely hard, and I know we're not talking about it, but it's interesting. That it lives on surfaces for a very long time. So even after they clean the ship, the next group of people, guess what? So not very good publicity. But why it's relevant, it's similar to Hep A and E, except high mortality in pregnant women. Okay? That's actually a board question. That always comes up. So here's where it is. If you notice, it's not in the United States, but it's in much of the rest of the world. Most outbreaks associated with fecally contaminated drinking water, minimal person-to-person transmission. U.S. cases usually have a history of travel to hepatitis E endemic areas. The incubation period averages about 40 days, range 15 to 60 days. Case fatality rate overall 1 to 3% of pregnant women, 1 to 3% overall, but pregnant women 15 to 25%. Illness severity increased with age and no chronic complications. All the boards I've ever taken always have this question. All right? I'm not going to go over that. Okay. So, if you're pregnant and traveling, avoid drinking water and beverages with ice. Because a lot of times you get a drink. Not really, you're trying to avoid the water, but you put ice cubes in your drink. Guess what? That ice cube came from water that was just taken out of a river with a farm north. All right? So no ice cubes. Uncooked shellfish, uncooked fruit, vegetables not peeled or prepared by traveler. You always want to have your food hot. All right? And if you're going to eat fruits, make sure it's fruits that can be peeled. Okay? And if it's raw and there's a lot of spice in it, that doesn't count as being cooked. Right? Doesn't count as being cooked. Immunoglobulin prepared from donors in Western countries does not prevent infection. Okay? Unknown efficacy of immunoglobulin prepared from donors in endemic areas, and no vaccine. Whoa. So I think the last two slides, which I'm not going to go over, actually is a big summary of just about everything that I've spoken about. And if you go over these two, with the first three slides that I show you, you will cover the vast majority of things that you need to know. And that's it. Actually, finish ahead of time. You have questions, or should I keep talking? Because I could. Any questions? Anything I need to clarify? Yeah, so hepatitis A and hepatitis B can give you lifelong immunity, but not hep C. Yeah, that's another difference between them. Yeah. But remember that hep C, that 70 to 80% of people have a chronic infection. So you can either stay chronic infected or you can reacquire. No. If you go back to your habits, if you go back to injecting drugs. But usually, we do very careful selection of candidates for treatment because the treatment is so horrible. If someone has a baseline depression, doesn't exclude them from getting treatment. But you want to make sure they're on therapy before you start. But if someone comes in with, rabid schizophrenia, probably don't want to exacerbate that with interferon, right? You do a screening for thyroid function, right? You screen and then you put the person on therapy. If someone is an alcoholic, you make sure they've gotten counseling against drinking and have them stop for several months before you start treatment. So we sort of reduce that risk that somebody's going to go back and put themselves in a setting where they could get re-exposed. Okay? But most of the infections in hep C is chronic, so sometimes it's hard to tell. Mm-hmm. Why children versus, I don't know. We don't know. We don't know, because same thing for hep A. Kids give you every single thing in the world. They're like incubators, petri dishes. I'm sure there's probably an immunologic basis, but you think that the immune system of adults is more developed than kids. But I don't know of an explanation for it. An important thing for hepatitis A, as I said, is that if there's an outbreak, that you need to go back 2 weeks from the time someone develops symptoms for contact tracing. So if someone gets, you go, where are you going to eat lunch later? Zestos? Right, that's idea. You go to Zestos and you eat today, and you develop whopping diarrhea and abdominal pain and so on. As an adult, the day you develop symptoms, we have to go back 2 weeks in the past with everyone that you have tossed a salad for prior. All right, because then that's when you're most infectious. And so the infection gets spread very easily because kids can run around and drool over everything. And they're dropping virus all over the place and they slob all over you. And then you get it, you come to your class and you hug your classmate and kiss your classmate and they get it, right? You don't believe the last part, right? Any other questions?